And again, this is our roundtable meeting with Dr. Rick Loftus, giving us some updates on health situations that are affecting long-term survivors of HIV and older adults with HIV. So Dr. Loftus, would you like to just share with us your thoughts for as long as you need to, and then we'll go into Q&A?
Yeah, I'll kind of just, tour the big three topics I think that are in people's minds. We'll talk about monkeypox. We'll talk about kind of COVID update. And then, I'll touch base on some of the highlights of the International AIDS meeting. And then we'll just kind of open it up. So monkeypox, it's been in the news. Total cases now is by CDC is 32,000 cases worldwide, about 11,700 in the United States. So we're by far and away the biggest outbreak among countries, 70 countries affected at least. So interestingly enough, I've learned that this strain that is now circulating so widely was first noticed by a practitioner in Nigeria in 2017. I guess they did sequencing, so they know that that's the same strain that we're dealing with now 5 years later. They've had about 300 cases total in Nigeria. But, they had been trying to draw attention to the fact that they were seeing slightly different behavior from this strain of monkeypox that looked more casually transmitted. I think most of their cases have been in young adults and not an MSM, distribution like it's been in Europe and the US. The world outbreak at this point, 98.8% men. Although I think the percentage in the MSM risk group for the States keeps dropping in prevalence. I think last I heard as of today was that, we maybe had 6% of cases not in the MSM community in the United States. But it's still predominantly been an outbreak in men who have sex with men. WHO is not yet advocating mass vaccination, but I think there is this focus on vaccinating people at risk, which they split hairs as to whether that means you were in contact with a confirmed case of monkeypox or you were, exposed to someone who may have had monkeypox, but just as an aside, I would say some of us were talking about the fact that, folks who are 48 or younger did not get smallpox vaccination, but most US adults over the age of 48 did get smallpox vaccination as kids. The half-life of the antibodies is something in the neighborhood of 80 years. So it's possible that adults, over 48 years of age may already have some immunity to monkeypox because of immunity produced by the smallpox vaccine, which is a closely related orthopox virus. And, I think some of us are trying to think that maybe we just need to reestablish immunization in childhood against orthopox viruses. Whether we're saying we're worried about smallpox or monkeypox probably is incidental. We need the immunity. New England Journal did a paper recently looking at 528 cases. And this was between April and June of this year. These were over 16 different countries. Median age of the monkeypox cases was 38. 75% of them were white. 41% were people living with HIV. And of those folks who had HIV, 96% of them were on antivirals and 95% of them were undetectable on their antivirals. 29% of patients had other STDs diagnosed at the time of the monkeypox. And I think, many of you probably have seen the popular media stories already, but monkeypox presents as a rash, what we call a vesicular rash or a blistery rash. They look like dewdrops on a rose petal is sort of, what we call vesicular rashes, but they look like little fever blisters. They can be in clusters. They can be in clusters on the genitals, in the anal mucosa, in other parts of the body. They can be clustered along the face. They can also show up as isolated blisters, like one on the leg here, one on the other leg. One sub-study of the New England Journal study looked at seminal fluid. Of 32 samples analyzed, 29% of seminal fluid was PCR positive for monkeypox virus. So the vaccine that we're using against monkeypox is a vaccine called Jynneos. It was originally approved for protecting against smallpox, and the intention was to use it in case smallpox was weaponized against the military. Jynneos is a viral vector vaccine, but it's non-replicating. That was to replace an earlier smallpox vaccine that had a replicating virus, which had a higher risk of side effects and also would be inappropriate for people with immune disorders. We don't give live virus or replicating virus vaccines to people who have weak immunity because we don't want them to get terribly sick with the disease. So the older smallpox vaccine, which we're not using, is ACAM 2000. It has about a 1.3% chance of giving people severe myocarditis, so that's considered an unacceptably high for a pretty serious side effect. There was an important decision made this past month because we have something in the neighborhood of, well, the FDA estimates that if we vaccinate all people at high risk of encountering monkeypox, we're talking about 1.6 to 1.7 million people getting vaccinated. We will only have 1.6 to 1.8 million doses by the end of this year in the States, and it's a 2-dose vaccine. It's given as 2 doses spaced 28 days apart. So one of the suggestions was that there was a study that was done that showed that you could use 1/5 of a dose you'd give in the muscle, like a flu shot, and instead deliver that fluid under the skin to induce an immune reaction. And in the study, which was very well done, they could produce immunity very comparable to the immunity that you would get from doing it the standard way, but you'd be using 1/5 as much vaccine. So that would allow, in theory, a lot more doses with the supply we have in hand. So that is what the decision has been made to do. The peak immunity from these doses is expected at 14 days after the 2 doses are completed. And we have no idea how long the immunity will last. And in this particular outbreak, we don't really know how protective this vaccine will be. In African outbreaks using this vaccine, which was in smaller numbers of patients, the vaccine immunity protection looked to be in the neighborhood of about 90%. But there's a lot that we don't know about it, and then, in fact, there are studies being enrolled as we speak to codify exactly how much protection people will get from this vaccine. The big issue, of course, with the monkeypox vaccine is that right now supplies are limited. I think Coachella Valley at least has moved forward with availability of vaccine at some of the health centers. I think, from what I understand, Desert AIDS Project has the greatest supply and is doing vaccinations, but I know it's available elsewhere. And I think other people on the ground there, like Jeff, can probably give a little bit more up-to-date information on how the situation is looking. I can tell you here in New York State, we only have 6 of our 60 counties who have a vaccine in hand for monkeypox. There has been no outreach to more rural areas like where I am at all. The doctors at my hospital are organizing our own grand rounds on monkeypox for a couple of weeks from now, but we have heard nothing from the state about supplies of vaccines. And my local MSM patients, I've been telling them to contact the LGBT Center in New York City. Right now, there are no sign-up slots for additional supplies of vaccine. In New York City, there was an availability about a month ago for 9,000 doses, and those appointments disappeared in 7 minutes after being put online. So it reminds me of when people were spending all day on the computer trying to get signed up for a COVID shot. It's kind of the same situation right now for monkeypox. So I'm sure we'll have more questions and conversation about monkeypox a little bit later in the session here, but that's kind of the talking points for right now, and talk in more detail later. in the Q&A. COVID. So the US COVID situation is looking better in terms of hospitalizations coming down. But it looks to me like things are gonna probably, I mean, the rate of decline is not as sharp as what we saw with the Omicron surge. So it's looking to me like we're kind of sloping into a higher plateau, kind of at a case rate level that's a little bit higher than we had in October of last year when we nadir'd after the Delta surge and before we hit the Omicron surge. I know right now in the US, 40% of counties are considered to have a high transmission rate, 40% are medium, the rest are low. Case rates are concentrated in Southeast USA and Alaska at the present time, and Montana. Almost 90% of the isolates are the BA.5 variant, which is a derivative of Omicron. BA.4/6, which is coming up the rear here and may overtake BA.5, is about 5% of the cases. In terms of death rates, we're still looking at somewhere in the neighborhood of 400 deaths a day in the United States. So that crunches out to about 150,000 deaths per year from COVID at present case rates. That's, I guess, better than 400,000 a year, which is what we were looking at earlier in the pandemic, but it's not like we're not seeing enough death. We are. In terms of Riverside County, I think there's about, right now, this week, it was something in the neighborhood of 790 cases a day. I think there's in Riverside County, there's almost 175 people in hospital with COVID. Only 19 of those are critical care in the ICU. That's down from the end of July, where it was about 220 cases in the hospital. So the hospitalization rates are coming down. Of those who are hospitalized in Riverside County, something like 2/3 of them are completely unvaccinated. And that's not a surprise. That's similar to what I've seen here in my hospital. 85% of my COVID cases are completely unvaccinated who get hospitalized. And the rest are folks who have pretty severe comorbid conditions or immune disorders. And so they were at high risk anyway, despite being vaccinated. I think we're still looking at about 6,000 hospitalizations a day with COVID across the US. So it's still a pretty bad situation. We're looking for people above the age of 50 to get their 4 doses of COVID vaccine. Folks under 50 should have 3 doses. One thing I've been saying to all of my patients, 3 doses is the series for adults. 3 doses is complete vaccination. 3 doses. I know that initially we talked about this as being a 2-dose vaccine. Every multi-dose vaccine we have ever used always has a 3rd dose at 6 to 12 months. That's true for Hep A, Hep B, HPV. It's true for shingles. Like every vaccine that is more than 1 dose always has a final dose at 6 to 12 months. And COVID is no different. So I've been telling all of my patients, don't think 2 doses is a finished job. It's not. We have elegant immunological data that tells us that there's a qualitative difference in the protection with 3 doses versus 2. So I tell all my adults to get 3 if they've been willing to get vaccinated, which out here, there's still about 1 in 6 who don't. And then I tell the older adults that they should get their 4th dose. Some of them have expressed wanting to wait because the Omicron boosters are expected to come out in September. In terms of the difference in performance, it looks like maybe with a dual moiety of Omicron and original strain in the vaccine, maybe you get twice as much neutralizing antibody compared to the regular vaccine. But that's blood studies and not clinical outcome studies. So whether having a slightly higher amount of neutralizing antibodies translates into meaningful differences in terms of who gets infected, who gets symptoms, who gets seriously sick, I don't know. Remember that the immunity that keeps us from dying from COVID is the T cell immunity for the most part. or at least more than B cells, although both wings of the immune system are involved, both in protecting from infection and protecting from illness. But I just like to remind people that sometimes we dumb down immunity to being 100% about antibodies, and the antibodies are only one piece of the immune response. And antibodies are helpful in preventing infection from getting established, but our goal with vaccination for COVID is not to prevent infection. Our goal is to prevent serious illness. And that's a lot about T cells, and we don't casually measure T cell immunity. But we do see clinical evidence that boosters do make a significant difference. In the Israeli studies, 3 doses versus 4 doses saw a difference of, I think, 85% in emergency room visits. So, boosting does help. We are working on some new vaccines against COVID. The United States has in the military research program a mosaic vaccine that is intended to produce immunity, not just against COVID, but against all of the sarbecoviruses. So that includes not just COVID, but SARS, MERS, and OC43, which is a so-called benign coronavirus strain that is a close cousin of the more dangerous ones. Don't know too much yet about what they're seeing with the mosaic vaccine in studies, but the intention here is to have a broad immunity that could preempt any future variants that may develop. We'll have to see what happens with that, but I think that's a promising development. We've also got at least a half a dozen nasal vaccines in the pipeline, and there's hope that those will be more tolerable in terms of side effects and at least as good in terms of protection, and perhaps even a little bit better in producing immunity against the mucosal surfaces where COVID likes to invade, or SARS-CoV-2, I should say, such as the nose. Although that said, RNA vaccines do a very good job at producing immunity in the sensitive surfaces, which is not something we expected them to do, but they appear to be pretty good at it. The Novavax, a recombinant protein vaccine, has been approved, is getting distributed. I have to confess, as somebody who had hoped that my vaccine holdouts would be willing to get the Novavax vaccine, and I had really been talking it up, there are within a 100-minute drive of me, only 6 locations to get Novavax, none of which are anywhere within a half an hour drive of my hospital. My own hospital is not currently carrying Novavax and is not expected to stock it, which is bothersome for me because, as I said, I have patients that have avoided getting the other vaccines, supposedly because they don't feel comfortable with the RNA or DNA technologies in the existing 3 vaccines on the market. Now we have a protein vaccine, and I was hoping I could convince them to do that one, but I can't give it to them if my hospital doesn't carry it. I didn't have a chance to look at Novavax availability in the Coachella Valley, and maybe somebody will know that and talk about it when we get to the Q&A. But in terms of vaccination rates in the US, we are doing better. At this point, 78, almost 79% of US adults have had at least 1 dose. So that is progress, but still, we're still behind a lot of the other developed countries as far as the vaccine uptake. But I'm glad to see that the holdouts are starting to move forward. And then finally, some things that came out of the International AIDS meeting. One interesting study looked at injectable cabotegravir, which is a new generation integrase inhibitor. So depot cabotegravir can be given as an injection every 2 months. And so one potential application for this is using it as PrEP to prevent HIV. In one of the studies, it was injectable cabotegravir was superior to oral Truvada or Descovy in preventing HIV infection, but at a cost of $22,000 a year. Criticism of the study was that, for low and middle income countries, a cost-effective cost for such an approach to preventing HIV would have to be somewhere in the neighborhood of $60 a year, and $22,000 is a lot more than $60. So whether we will be able to take advantage of this technology in resource-poor settings seems kind of dubious at this point, and we'll have to see what ViiV has to say about that, which is the company that makes it. Another big story, which some of you may have seen in the media, the City of Hope patient who was in one of the studies, which my team was trying to recruit patients for, but it was very hard to find people who were eligible. But there was a patient, this is probably the fourth patient to be cured of HIV, although John Zaya, who's a close friend of the research and patient community for HIV in Coachella Valley, John said he wouldn't consider it a cure until the person is 5 years out undetectable for HIV, but the patient is now at least 17 months out with no HIV being detected. The patient is 63 years old, was diagnosed with HIV in 1988, has been on antiretroviral combination therapy since the mid-90s, got diagnosed with acute myelogenous leukemia, which is, has a high death rate, and so was treated with a stem cell transplant. And so what they do is they wipe out your immune system, which kills the leukemia, and then they replace your immune system with a transplant of stem cells, which regrow the immune system. They used stem cells that had the CCR5 delta 32 mutation, which is the mutation that removes a receptor for HIV. So remember, you get a copy of every gene from mom and from dad. So if you get a mutated copy from both parents, then you don't make any receptor for HIV of that type, and that makes your cells more resistant to HIV infection. It's not impossible to infect them, but they're quite impervious to HIV infection. And so by regrowing this immune system that was naturally biologically resistant to getting HIV, it looks like the patient has essentially been in a remission. He has been off antiretrovirals now for almost 1.5 years with no detectable viral load in his bloodstream. Occasionally, they have found certain mononuclear cells, which is a type of immune cell with some very low amounts of DNA detectable for HIV, but the patient has not had a detectable viral load in his bloodstream for the last 1.5 years. So that was some excitement there. And then the final study I wanted to mention from the International AIDS meeting was a study of doxypep, as they're calling it. So this is the idea that, after a sexual encounter, you can take a dose of doxycycline, 200 milligrams, which is the same dose we give people for a tick bite if they're worried about Lyme disease exposure. So they take a 200 milligram dose. This was a study done by Annie Lutkemeyer, who was in fellowship with me at San Francisco General. She was the lead investigator. The study was done in 554 people. And what they found was a 60% reduction in gonorrhea, chlamydia, and syphilis rates in people who did doxycycline after a sexual encounter as a form of kind of post-exposure prophylaxis against those STDs. This is similar in results to a French study that showed reduced rates of chlamydia and syphilis, did not see a reduction in gonorrhea, which makes more sense because doxycycline does not treat Neisseria gonorrhea. So, but in the San Francisco study, they did see a reduction in that infection as well. So that's maybe another tool in the armamentarium to help prevent STDs in folks who may have high risk exposure. So I think that's it as far as updates on our 3 favorite viruses, or at least the viruses we're talking about. So I hope that was some grist for the mill. I have no doubt that people have some good comments and additional information about the situation there in the Valley, and probably some good questions as well. So I'll pass it along to our facilitators and we can take it from there.
Thank you very much for that update on those 3 viruses. As you said, that was pretty comprehensive, and I do think gives us a lot of information to talk about. So just to reiterate, because some people joined the meeting later, if you have questions, feel free to write them in the chat, or you can use the raise hand feature. That way we know that you are on deck for a question, and we can get to you as soon as the opportunity comes up. There are also I did notice some questions in the chat, so I'm going to hand it over to Blaine to see where we go next.
Okay. Terry, did you want to ask your question yourself, or shall I go ahead and read it?
You can go ahead and read it.
Okay. Terry was asking, can you speak to the restriction by Los Angeles, New York, and others to restrict monkeypox vaccination to 1 dose. What is the data on only using 1 dose, especially using 1/5 dose? Anything specifically related to immune response by those with HIV?
Yeah, that's a great question. And the truth is, part of why a 1-dose strategy wasn't put in any of the research studies that are looking at efficacy of the vaccine in this outbreak is that there's no scientific rationale for a single dose. I assume that the idea here is similar to what the United Kingdom had in mind when they were deploying their vaccine rollout for COVID, and they were not doing second doses as soon as 3 to 4 weeks, but were waiting and doing them later, partly to expand getting initial immunity into their population. I think the idea is that there will be a second dose somewhere down the line. Do we have data about the effectiveness of that approach? No, we do not. And that is why at least one research group decided they would not study a single dose strategy, since we have no, rationale for thinking that that will work sufficiently. Is it better than nothing? Probably. Do I think it will work as well as 2 doses, any distance of time apart? No, I don't. But we do have good evidence of the comparability. When you look at antibody response titers, when you compare standard dose Jynneos vaccine injected in the arm, in the deltoid muscle, versus intradermal delivery with 1/5 of the dose under the skin, the immune responses look comparable. In fact, even like the side effects of fevers or soreness at the injection site and so forth are pretty comparable. I think there's more skin irritation for obvious reasons when you do it under the skin, more kind of itching at the site or redness at the site, and I think more pain at the injection site for the intramuscular injection. But in terms of how well using the 1/5 of the dose under the skin will work, looks like it works at least as good as doing it in the deltoid. And I think that's good news because we'd like to have everybody get multi-dose series. Right now we consider dosing of this to be 2 doses. Keep in mind, again, we don't know how long the immunity lasts, and we don't really know for sure how much protection, that confers with that vaccination. In older data in a completely different situation, it looked to be about 90% protective. But that was also with people who were getting, let's say, less robust exposure. We're talking about folks whose exposure might be prolonged skin-to-skin contact. That's a pretty heavy exposure to protect against. Whereas when they were, studying the vaccine efficacy in the outbreak in Central Africa, they were talking mostly about household contacts who were maybe being nursemaid to somebody who was sick and handling like infected washcloths and things like that. And that's still an exposure, but maybe not quite as heavy an exposure as what we've been seeing with a lot of the cases in this outbreak. So we don't really know yet what the protection is going to be. But, I think we should endeavor to make sure that single doses are followed up as quickly as we can with a second dose. Does it matter if it's 2 months or 6 weeks later than when we would normally do the second dose? I doubt it. But, having worked in immunology for, 25 years now, and, working on vaccines myself, like I said, multi-dose vaccines, there's always a final dose, for multi-dose vaccines at 6 to 12 months. If we're in a hurry because there's an emergency, we'll usually do 2 doses about a month apart. That's the I'm in a hurry vaccine strategy. Does that mean that we might have 3rd doses of monkeypox vaccine 6 to 12 months from now? Could be. Wouldn't surprise me if the conclusion was that there'd be an advantage to boosting. Hopefully by then we'll have a more robust vaccine supply and that won't be a big deal. Certainly that's the way things fell out with COVID. But I think, as with anything else, there was a wonderful essay in the Lancet about how important it is for those of us in the affected communities of patients and providers taking care of patients, at risk for monkeypox, to be advocates for our community. I was pleased to see that at the Montreal International AIDS meeting, many of the advocacy organizations, sort of pointed out that all the same mistakes that muffed COVID happened with monkeypox. And if you don't think homophobia had something to do with it, it did. When this was killing people in Nigeria for the last 5 years, no one cared. No one thought to supply them with vaccine. They have no supply of Jynneos at all. And they're seeing, people die from this. It's, estimated 1% death rate for the strain that's circulating. But in Nigeria, they're seeing people die from this, and nobody gives crap about having, vaccine for them. And when it was just gay men in Europe and the United States, it still wasn't enough of an emergency to crack open our vaccine supply, because what if somebody did a terrorist attack against our military with smallpox? That's what this vaccine is for. So eventually they started to realize that we were in big trouble, and then the vaccine became available for civilians. But, was that delayed by about 2 months? Yes, it was. And was that a mistake? Yes, it was. And should we have had a better leg up on this outbreak because we already had a diagnostic test, a vaccine, and a medication to treat it? Yes, indeed, we should have. So it's all the same mistakes. And a regime change does not seem to have made a big difference at CDC. I know a lot of people left when Rochelle Walensky came in. So I think losing some of that institutional knowledge certainly makes things run not as smooth. I can tell you, working at a small rural hospital here that's had a lot of personnel leave, it's a lot more ambiently chaotic, because the people who knew how to make things happen quickly, or who knew people in the other departments, they're all gone. And so those who've replaced them are just not as familiar. So, healthcare every place is a little spottier than it used to be. I heard an interesting statistic on the Osterholm report a couple of weeks ago on Mike's podcast, that 47% of public health workers in the United States are expected to retire or leave the field in the next 5 years. And our public health system is on its last legs and limping along. So while we all may be really mad about things that, didn't happen in dealing with monkeypox, basically healthcare and public health workers have had the shit beat out of them for 2.5 years. And a lot of people are gone. We're missing a third of our nurses. We're missing 20% of our healthcare workers in general. And as I just mentioned, we're imminently about to lose a lot of the public health workers who are still in the field after COVID beat the crap out of them.
Yeah,
so
that's really
as I
alarming.
about this, I'm also feeling like, there's reasons why this happened, and some of it's explainable, but it doesn't mean that it's forgivable, because we're still behind the 8 ball now with monkeypox.
Yeah. Jeff, did you want to follow up with some information on that? You're just muted.
Right. Yeah, Rick was saying about the public health strategy here locally. So if you've been going to the town halls or on the task force meetings, the county did decide to just get shots in arms as quickly as possible. After about the first week or so, we started meeting with them, and they realized how up in arms the community was about this. They said, we're just going to get them out. More are on the way. And as Rick was saying, it probably doesn't matter if it's, exactly 28 days or 6 weeks or 2 months. You get protection. And maybe Rick can speak to this better than I can, but as I understand it, people who've already had the smallpox vaccine have pretty good protection after the first shot, better than someone who doesn't. So that helps.
Yeah.
Us anyway.
Yeah, I agree. And I think we don't yet have a guideline that's telling us, hey, for those of you who are 50 plus or 48 plus, you can probably just get your 1 dose and you're done. But we may see an advisory along those lines. I think those studies are probably being done right now to verify that understanding. But we think that may turn out to be true, which means that, a certain age group is going to be able to get great protection just from a single dose after all. And that's a good point to mention.
Great. Blaine, I'm
Dr.
sorry.
Loftus? Oh, I'm sorry, Alex. Go
I was
ahead.
just going to hand it back over to you because I see we have
Oh.
some hands raised.
Yes, and before we get there, there was a second part to Terry's question. Is there anything specifically related to immune response by those with HIV, and any general recommendations about monkeypox for those with HIV?
Those are great questions. And right now, we don't know for sure. I can tell you in broad strokes that we sometimes do find in folks with HIV that they don't respond as well to vaccination. I think that was more of a concern in the world where we had unsuppressed HIV that was untreated, because that causes a lot of inflammatory activity that makes the process by which a vaccine trains your immune system, which is something called antigen presentation. Antigen presentation is very messed up in untreated HIV. But when we suppress the virus, we see an enormous improvement in immune function. And so I'm optimistic that we'll see. So far, it looks like we've had pretty good luck with COVID vaccination conferring equal protection to folks living with HIV, since most folks with HIV are on treatment and suppressed and therefore have immune systems that are mostly working pretty darn well. So I'm not as worried about that, but I think we won't really know for sure until the data comes back. So, check this space in another probably 6 months and we'll start to have some hard data speaking to that question. But right now, I'm not super worried that folks with HIV, if they're on therapy, are going to fail to mount an immune response. My impression with the Jynneos vaccine is that it is very immunogenic. So I expect it to be a pretty strong vaccine that gives a strong signal to the immune system. But as we saw with COVID, the question will also be like, how durable is that immunity? And we don't really know the answer to that either. That's still an open question. But I would say for folks who are on their meds and suppressed and their HIV is undetectable or pretty close to that, are probably going to be able to respond well to the vaccine. In terms of whether monkeypox is more dangerous or more likely to disseminate, I think we've started to get the impression that the way that monkeypox is looking in this outbreak, which up till now has been 98% MSM with heavy skin-to-skin contact as the transmission, that it's looking a little atypical. We're seeing lesions that just show up as like a single speck on a limb, which is not usually how it's portrayed, typically in the classic presentation. But we're also, as I mentioned at the beginning of this, the impression from the Nigerian physicians is that this monkeypox strain was behaving differently, and they saw it being more contagious and had more of an outbreak there than had been true of previous outbreaks with other strains or other varieties of monkeypox. So we may be dealing with a version of this virus that's a little trickier, but we are getting some impressions that we're seeing unusual presentations. One thing, that Dan Griffin from New York always talks about on This Week in Virology is that patients are allowed to have more than one infection. And as I mentioned, 29% of the patients in the New England Journal study had another STD besides the monkeypox. So I think it's important, when we're looking at a lesion and we're not sure what it is, that we don't just test for monkeypox, but we test for other things. Monkeypox needs to be included, but people are allowed to have more than one infection at the same time. And I think we ran into this problem with COVID, where it was like, if you had flu, then they didn't test you for COVID. Guess what? You can have both. And so in the same way, I think that we should not, test people for other STDs. And if we find one, say, well, that's what you have, it's this disease and not monkeypox, because you could have both. Part of that is making sure that clinicians know where they can send samples to get testing. All of the big three laboratories, LabCorp, Quest, and Mayo Clinics, all have testing available. And there's some other lab systems that also have testing available now. And most hospitals, contract with at least one of those entities. So I think availability of testing is theoretically there. Whether the frontline clinicians know what to look for and know how to use those tests is an education gap that still has to happen, which is why yours truly is giving a grand rounds on this subject at my hospital 2 weeks from now.
Awesome.
Thank you. T, please go ahead.
Two things real quick. I did get my monkeypox shot yesterday at Des Oasis Healthcare, so it is out there. I worked all the clinics I could, and finally one said yes. But for a second shot, should I be concerned if they say, well, for the second one, we're only doing the subdermal, the little itty bitty, or do I need to get exactly what I got the first time?
Nope, we already have data that a second as a dermal injection will work just as well as getting it in the muscle. It doesn't compromise anything. It works just fine.
Okay, the second question is, back to COVID. I had 4 shots, and when I was kind of timing out my 4th shot, I was getting kind of old and long in tooth, whatever. My doctor had me do Evusheld, and my next Evusheld is October 12th.
Yep.
And that's about the timeline when they think they'll have the updated vaccines.
Right.
Which would you take? Because isn't there a delay factor? If you get Evusheld, you can't get a vaccine because it kind of rebuffs the vaccine for like 6 to 8 weeks. Would you take one or the other, or what would you do?
It's a good question. So Evusheld is just antibody immunity because it's a monoclonal antibody. So it's only one kind of immunity. It's a good kind of immunity, but it's not, remember, your antibodies are just one component of a full immune response. And a lot of the immunity that makes us not get terribly sick from COVID is the T cell immunity, which is developed by vaccination. So I think if I had my choices, and I don't know if they're going to present these Omicron boosters as a 5th dose option. In other words, like, will we allow like a 3rd booster using the nomenclature that we've used for doses? I just count the total number of doses, because as a vaccinologist, 3 doses is the series. A 4th dose means you were older or had a chronic condition or both. So if we're talking about a 5th dose, I'm not sure if they will be authorizing a 5th dose for these boosters. So we should know that fairly soon, but right now there's no 5th dose protocol. And most of the institutions are going to say, well, the CDC has to tell us we can do a 5th dose if you're going to get it. So in the case that they're still waiting on authorization to give a 5th dose, I would do the Evusheld as a plan B, but I would put it secondary to using a true vaccine, because a true vaccine develops all of your immune response rather than just giving you some antibodies passively. Does that make sense?
Yeah, and is there a waiting period after getting the Evusheld before you can get another vaccine? And
that's a good question, and I don't know off the top of my head, but I can find out for you. So let me look that up, and I'll answer you in just a bit.
For people who may not know what Evusheld is, and someone.
Oh yeah, I'm sorry. And right, I should probably explain that. And thank you for asking about Evusheld. Evusheld is a monoclonal antibody infusion. And people may remember that there were these monoclonal antibodies used to treat infection when people got COVID. You may remember that when President Trump got COVID, they used the Regeneron monoclonal antibodies to treat him so that he didn't die, because he was pretty close to that. But the Evusheld is not for treating the disease, it's for preventing infection. And so it's used for folks who maybe are, say, for example, on immune suppressive medications where we don't think they'll respond to the vaccine very well. For example, we know that people who are on methotrexate, which is used for certain kinds of rheumatological disorders, don't really respond to any vaccines all that well. And so if we think they're not going to really get a benefit from vaccination, we can instead give them outside antibodies to protect them. And that's this product called Evusheld.
Thank you.
And it shows, I've been hearing Evusheld is showing to be protective against BA4 and BA5.
Yes, and that's interesting because, we're always worried that as these variants continue to evolve, they'll slip around these. Once the Omicron varieties became a thing, I think they changed the dosing regimen to up the antibody levels. And it's counterintuitive, but we always talk about how specific antibodies are like a lock and key, but the dose kind of does matter. If your antibody's only so good at matching the antigen, if you give a crap load of it, it sort of overcomes the problem of the antigen being a little more slippery. So even though Omicron's a little bit more slippery than the original strains we were dealing with, or the Delta and prior strains, we can give more antibody than we normally would have and get around that and get a decent immune protection anyway. So they upped the dose of the Evusheld. So now we use it at a higher dose, but so far that's held against the Omicron-derived variants. That's right.
Thank you.
Thank you, Dr. Loftus. And Dr. Loftus, you're looking up the answer?
On the Evusheld and vaccination.
Yes.
So but you can throw another question at me in the meantime. I can multi.
Richard, would you like to ask your question?
Yeah, sure. Dr. Loftus, can you explain exactly when monkeypox is transmitted? Does the lesion have to be open? Can you just have a pre-open lesion? Can people transmit it when they have no symptoms from the skin?
The virologists are asking that exact question right now. So our impression is that before people develop the rash, they're not 0% contagious, but they're a lot lower contagious, we believe. How much lower, we don't know for sure. And that's an active question that's being studied in the outbreak right now, because it would be very helpful to know if folks that are not symptomatic could still be at risk of infecting others. We don't know the answer to that right now. In theory, there is some shedding of virus before you have the rash, but we know that once the rash develops, the amount of virus coming off your body is a lot higher and you're a lot more contagious at that point. We do believe that once people have healed up a lesion and it's got new skin underneath it, which usually takes 2 to 4 weeks, at that point, their infectiousness resolves and they're no longer contagious. But I think that's why the isolation period for monkeypox cases is 4 weeks, because we assume that people may be contagious at least as long as that. I don't know if that answered your question.
Well, it's getting closer, yeah. So if someone has monkeypox, the virus can be transmitted from skin and not only from the pox. Right?
Right. Well, like, could skin before it develops a visible blister have virus in it that's transmissible? Could be. I don't think we know the answer to that. We know that it gets into body fluids, and we know that even before people have the rash, they typically will have what we call a viral prodrome. So they'll have flu-like symptoms, achiness, fevers, those kinds of symptoms. And it's likely that at that stage, their fluids have monkeypox in them, their saliva. We already mentioned that most seminal fluid that's been collected and studied is positive for monkeypox virus. So it gets into the, sexual fluids. So I would expect that somebody, even before they had a visible skin lesion, if they were in the prodromal period, they probably do have contagious virus in their fluids. Whether unbroken skin will have it, I don't know for sure, but it wouldn't shock me if that turned out to be true. But I don't think we know yet. And that is something that's being looked at. But I would say that I would expect somebody who is prior to having the rash, that, a lot of folks will have other kinds of non-specific viral symptoms. So, I mean, this gets back to the world before COVID, where people would like go to work sniffling and what have you. And, I think COVID has shown us that, like, when people are sick, they should just bloody stay home, right? Don't give other people your virus. So if somebody develops flu-like symptoms, hey, go isolate, stay home, because you might have something that you might spread to other people. And, it could be monkeypox. So, it's just common sense. If people are developing some of these, viral symptoms, they should do the right thing and not go to work, not, go out and socialize, because if you might be contagious with something, you don't want to give it to other people. So, I mean, I think, my mom always said, if you're sick, don't go to school because you'll get other people sick, stay home. And, I do what mom says. So that was just good practice. But I think we're looking at kind of the same advisory being true, just like for COVID as for monkeypox, is that, if people are, having suspicious symptoms, achiness, fever, what have you, they should probably, be concerned they might have some kind of virus, who knows which one, but it's probably better to stay home and not socialize until you know what's going on.
One last thing, what's the incubation period after exposure?
Yeah, I think the average incubation is like a week, from what I've read. And it can vary anywhere, I think, from 5 days to up to, I think, 20 days. Yeah, so it's pretty broad. I mean, all about this virus is inconvenient, right? Because if somebody gets sick, they have to isolate for a month. Like, none of this is going to be easy to accommodate. This is even worse than COVID in terms of isolation precautions. So, but yeah, that's the numbers.
It's pretty disturbing.
Yes, viruses are fun. This is why I study them, because I want them to stay very far away from me.
Yes. Thank you. Thank you for your interest.
Yes. By the way, so I found the answer on Evusheld. So it is recommended that if you have received Evusheld, you should wait 2 weeks before. You should wait to get Evusheld until 2 weeks after you've had your vaccination. But if you've already got Evusheld on board, then you're considered to be protected for 6 months. But I'm still looking to see when they would recommend that you do a vaccine dose after Evusheld is onboarded. So I'll get back to you on that question. Why don't we field another question in the meantime?
Okay. Alex, and then Terry, and then there's some questions in the chat that I need to get to. So Alex.
So Dr. Loftus, you said that about 11,000 people in the United States have had monkeypox, and we're rushing to get people the vaccine. I guess I'm just wondering is the horse out of the barn in terms of totally containing it? Is that a strategy that we can work towards? Or is it just going to become endemic? Or is it going to be like this with COVID? Or what's going to happen?
I think a lot of us are worried that we kind of missed, the boat on preventing this from becoming endemic. I'm very concerned. I think a lot of virology and public health people are worried that this has gotten far enough into the general population now that it's going to be hard to contain it. This is part of why I feel like we all need to bang our shoe on the table, that we goddamn got to get vaccination in every gay man in the United States as fast as possible, because it's going to spread. And we've already got 11,000 people, 98% almost of whom are, gay guys. So our high-risk community needs to be prioritized for vaccination. And honestly, like I said, a lot of us, amongst ourselves are already saying we should just reintroduce orthopox vaccination as a childhood vaccine in this country, because I don't think monkeypox is going away anytime fast. And it can spread through non-sexual contact. It's not like it's just going to limit itself to, the kind of intimate exposures. People could potentially get exposed to this. There was a case in, I think, Illinois or Indiana of a daycare center where a worker came down with monkeypox. And of course, once there was concern that children could get this, then all of a sudden, the powers that be started to take this a little bit more seriously. But I think we may be looking at dealing with monkeypox for a few years yet before we got it contained. Whether we would be able to eliminate this, I don't know, but 11,000 sure sounds like a lot of people to me, because of course it is only the cases we've recognized, and there are more cases where that came from that we haven't identified yet, and it's contagious. This kind of reminds me of some of the discussion we've had around COVID, where I had to remind people again and again, your vaccination is not equivalent to a bulletproof shield. Your vaccination is partially protective. Please be smart about your exposures. Please mask up. I still wear an N95 inside every single building I go into with goggles, without exception. Is it awkward? Sure. Am I the only one in my price chopper who's wearing a mask? Yes. Do I care? No, I'm a clinical virologist and I don't want this goddamn virus. And I know what it can do to people because I've seen people disabled by it. I use my brain for a living. I don't need long COVID brain fog getting in my way. And, I've coached my whole family to be the same. And a lot of my family members say they're the only one in the grocery store wearing their, masks. But, we got to mask up for COVID. We need to be smart about, exposures right now to monkeypox. It is circulating. And I think, I've heard some of the advocates say, we need to talk about, telling people to wait until they've gotten vaccinated, and kind of, limit numbers of partners. That was a strategy, during our early AIDS as well, as we were trying to figure out, how to prevent HIV. Eventually, science will give us better tools on this, but I think we need to be recognizing that we've got another virus that's threatening our community, and we need to do what we can to slow its spread. And that includes just not, casually having more risk of exposure than we need to right now, certainly until at least we get vaccination on board. And we need to really advocate strongly for mass vaccination of the gay community as a high priority, because it's spreading like wildfire. And that's not just in our interest as gay men, it's in the interest of the United States, which goddamn should have put Janaeos in the hands of the Nigerians goddamn 5 years ago, and this wouldn't have happened. But here we are. So I don't have to revisit the social justice aspects of viral outbreaks. I lecture on this all the time to my residents med students. And it always seems like I'm editorializing, but of course it's the whole heart of the matter. We'd have a lot fewer of these nasty viruses around if we took the attitude that we're not safe until all of us are safe.
Thank you very much.
Thank you, Dr. Loftus. Terry, and then I have a few questions in the chat, and then I'll come back to you, David.
Hi, thank you for saying that. I think we're all feeling that passion. I'm going to add a second question directly related to what you just said, but I'd like to also start with indirect contagion. Can you drill down into that a little bit? Sheets, pillows, towels, gym equipment.
Yeah.
The whole notion that the virus can live for 15 days on a surface. Is it contagious? Is that one of the ways it's spreading? Is that just in theory, but not in the real world?
Right,
Can you
right.
talk about
And
that?
we'll all remember when we were talking about like how many days COVID would, the COVID virus would survive on steel surfaces versus cardboard. And I mean, I remember those conversations too. And all of that turned out to be kind of irrelevant because it really turned out to be all about breathing shared air. And that's really the way that COVID got spread. And the fomites, as we call them, or objects and surfaces, wasn't nearly as important. Probably not impossible to get it that way, but not very important. For monkeypox, it's more important, the object contamination and exposure. So that is more significant. The recommendation is that, all clothing, bed clothes that a person who's had a case has had needs to be laundered separately. The recommendation is that the laundering be done by the person who has the monkeypox and not others who might have to handle the laundry and potentially get exposed. Soft furniture that the person may have spent time on, like a couch, does need to be cleaned with cleansers. The CDC has a list of approved cleansers for killing orthopox. I think it's rating Q for monkeypox. So they actually have a rating for which products are strong enough to be used for decontamination of surfaces. But yeah, it's more significant. Is this something where somebody needs to be worried that, going into a public bathroom and using a toilet seat is going to give them monkeypox? Not super high risk, not utterly impossible, but I think again, we're in a new outbreak and this strain might be a little different than the earlier monkeypox we were familiar with. We do consider monkeypox to be contagious on surfaces for some period of time afterwards. And we do think that, there needs to be decontamination. But whether somebody like using a public facility and having to worry about touching a counter in a bathroom or something is going to expose them, I don't think it's zero risk, but it's probably not very high risk. Kind of in the same way that we saw with COVID. But to some extent, to be fair, this is yet to be seen and we'll have to find out. Right now, I think like we did with COVID, I remember when we were all washing our chip bags after they were delivered from the grocery store. We don't need to do that now because we've kind of figured it out. We'll learn from experience, but I think we should probably, I'm a big believer in the precautionary principle. So I would consider right now object to be of enough concern that if an object was, in contact with somebody who was a contagious case, you should take decontaminating it seriously with approved cleansers. We'll watch and see over the course of this how important surfaces or objects are. But we do consider clothing and bedclothes to be a hazard. We don't recommend if there's, if somebody's had like laundered clothing folded and put away in a dresser, they don't need to re-launder their clothes because someone in the household had monkeypox. Even in the traditional outbreaks in Central Africa, not every household member contracted monkeypox just because somebody in the house had it. But the ones that were at highest risk were the ones who were nursemaids to people who were sick, and they were of course handling washcloths and bandages and so forth, and that's probably how they got exposed. I don't know if that answered your question though.
It answered most of it, but probably the one place that a lot of gay men congregate regularly is at the gym.
Yeah. Well,
And
I think I'll remember using, hypochlorite spray to clean off bench equipment. In theory, a good gym still has that. I remember when we were seeing the MRSA outbreaks that were associated with gym use, and, that just kind of reinforced the importance of, wiping down surfaces with virucidal and bactericidal cleansers. And so, yeah, I think the gyms are going to have to bolster all of that again. They were doing some of that with COVID as well. We're just in a world full of viruses, so we just have to be smart about cleaning surfaces. And I think we just need to make sure that the gyms know to look for cleansers with the Q designation. There's like an alphabetical scoring system for which cleansers are strong against what infections. And so Q is the code for cleansers that are considered to be suitable to protect against monkeypox. So that's what we need to tell our public spaces like our gyms, is to make sure they're using cleansers with that.
so given there's fatigue over that, and most of the gyms have abandoned that, and the public health requirements have all been weakened. I'm concerned both for myself because I want to go back to the gym, but also there need to be new public health orders about that. It's not a protocol that anyone's following anymore.
Well, so yes, I mean, I'd say this would be a good opportunity for some advocacy to ask public health, remind the businesses that they have responsibility to cooperate on preventing infection of nasty viruses. I mean, prudent behaviors. I mean, just because everybody stopped wearing masks at the grocery store doesn't mean it's not still a good idea. It's just a lot of people are just shrugging it off. Will they learn the hard way? Some of them might. Do I mind looking like, goofball wearing my mask in the grocery store? Hell no, because I know what's at stake. But these businesses may need to be reminded by a higher authority, not to mention just hearing from the customer constituency that they expect. I mean, this is for businesses that are LGBT owned. I should think that they would have a vested interest in protecting the community, and this is just another way to protect the community. I should think they'd be proud to put up a poster saying we are using rated Q cleansers to clean our facility because of concerns about monkeypox. I mean, this is like businesses that touted their ventilation rates and they're, keeping the environment safe for customers. It's just good business. So I think between, the customer community, advocating and maybe knocking on the door of public health and asking them to send out a reminder to the businesses that, surfaces need to be cleaned. I mean, we need to do that anyway. So we'll just need to reinforce the message. But yeah, I would say that's an opportunity to do some advocacy.
Okay, and then my last question circles back to what you were venting your spleen about, for lack of a better way to put it. I'm horrified at what I read about what happened with those vaccines in Denmark. Absolutely horrified that the US owned all of them and then they got snatched by Europe because we were laying on our asses. And that's why we have none of them. And Europe has hundreds and hundreds of thousands of the vaccines that we paid for that we just simply didn't order. It's so enraging. And the homophobic part of it, which underlies it, is so familiar to all of us. It's so damn familiar. If we, and here we are in Riverside, and there's an enormous shortage. It's a vaccine shortage, a vaccine desert here in the desert. People can't really get them easily. And I went to LA to get mine.
Yeah.
I'm wondering if you were to make a recommendation in terms of advocacy, if our community, which I believe it's time that we have to, again, stood up and started advocating, what would you recommend as a couple of the key demands that we should make in advocacy to kick them in the butt and say, you got to do these things? What are those things?
Well, we need to make sure that where LGBT people get their health care, that the provider community, which is, the HIV societies connect with most of the doctors that are going to reach the high-risk communities. So working with, the HIV Medical Association and AVM, and, making sure they're reaching out to their providers to make sure they are equipped with practical knowledge of how to vaccinate, who to vaccinate. One important point that's, I'll mention here is we know that people, but both in animal models and in live cases now with this outbreak, people who get antiviral medicines for their monkeypox do not develop protective antibodies and must be vaccinated despite being treated with medication. So just because someone gets antivirals for monkeypox, the drug is called tecovirimat, does not mean that they, get immunity from fighting off the infection. They still need to get vaccinated. So those are important points that our frontline clinicians need to have. So we need a massive education campaign so that the medical providers know what to be doing with these vaccines, know who needs them. I mean, my God, I got to tell you, there are so many imbeciles when it comes to COVID. I've got doctors who just won't prescribe the antivirals because it's like, oh, I don't know anything about that. It's like, bitch, crack a book. I get so sick of frontline medical providers who are just like lazy and don't want to learn about new technology. We've got a lot of new viruses. People need to roll up their sleeves, learn the medicine, and take care of their patients. And so the patients need to, the good news is that the medical community that takes care of the LGBT community are motivated providers. These are people who are living with these threats themselves. Their families are being affected. Their lovers are being affected. So this is a very motivated medical community. So I don't think we'll see that kind of problem with clinician education the way we did with COVID. But I'm still dealing with like boneheads in the community who just don't bother to learn anything about COVID therapy. And the patients are disadvantaged by that willful ignorance. We won't have that problem with our providers, but we need to really motor to get them the information they need in a hurry. And, that's already happening. CDC and FDA are collaborating on, clinician education. I was reading a bunch of slides that Jeff Taylor forwarded to me because I couldn't sit in on the COCA because I'm a doctor and I was working. But I have those slides and I'm studying them. And I think a lot of us are paying attention to this. But I do think that we should, get our, HIV clinician organizations to help out. I mean, in the same way that we had a better COVID response in the Coachella Valley because of the advocacy of Jeff Taylor and, a hard PS, we had institutions that were knew about dangerous viruses and how to motivate a community to respond to them. And that was invaluable. I mean, the whole larger community benefited from our knowledge as a community that has dealt with lethal viruses and knows what to take seriously. I mean, I've seen enormous vaccine uptake amongst gay men. Like, I don't see anybody as a holdout for vaccination against COVID because we know what we're talking about when we talk about viruses that are trying to kill us. And so I'm optimistic about how we'll do. But yes, we need a mass, advocacy campaign demanding that, all gay men get offered the vaccine as soon as possible. I think moving, towards this intradermal dosing will hugely expand our available vaccine, which means we shouldn't be leaving anyone behind in terms of delivering vaccine to people who want it. And that's a step in the right direction because we need to do this in a hurry.
Well,
Thank you.
currently, just as a follow-up.
Harry, I'm sorry. Let me just interrupt you for just a second. It's 5:10. Dr. Loftus, we didn't talk about an end time for this meeting. Are you available to keep going for another 20 minutes?
A few more minutes. I probably need to go to dinner, but yeah.
Okay, a few more minutes. Okay, so Terry, are there any other questions, Blaine, that we need to get to?
There are two questions out there. One might take a while, and that's Jonathan's. Just that he's unfamiliar with monkeypox diagnostics. So he was asking for a little more information on that.
Okay. Yeah, so, and by the way, on Evusheld, so apparently there's no definite information about how long you wait after getting Evusheld to get a vaccine dose. But the expert opinion, which I found, is that the recommendation would be, if you're going to do a dose of COVID vaccine, to do it a month before you're due for your next Evusheld dose. So that's the recommendation, is to do it a month before you'd be due for your repeat dosing of Evusheld. That's probably when you're going to have the least interference, although there may not be any interference from the Evusheld on your vaccine response, but that's the recommendation. So it's expert opinion. It's not a study-based answer, but that's the best I could find out. As far as how do we test for monkeypox, we swab the lesions and we use a dry swab that then is sent for sequencing, and we check for monkeypox genetic material in the swab. So we're using a non-cotton based swab. We're using a Dacron swab, and then shipping it off. There are also viral cultures, but to my knowledge, that's not the technology we're using for monkeypox. It is the technology we would use to check for a herpes virus. So if you're looking at a blistery lesion and you're not sure if it's herpes simplex or monkeypox, you send one swab in a viral culture, which is like a liquid. You put the swab in the liquid and send it off for viral culture. And then you do a dry swab that's then sent for monkeypox sequencing. And other question?
Yes. GSH asks, there is yet another shrew origin virus which has infected 35 Chinese. Is this the next on the horizon to follow more?
Yes, Henipa virus. It's a Henipa virus. And all the virology nerds have been talking about that when we're not talking about Crimean Congo hemorrhagic virus, which is a private joke to Jeff. But, we were chatting about dangerous viruses circulating. And yes, this new one is a Henipa virus. I think they're calling it Lengya virus, which is thought to have an animal reservoir of shrews. They're finding it in China. It causes a febrile illness. It's a small outbreak, so we don't have enough numbers to know if it poses much of a threat. So far, there have been no deaths reported, just febrile illnesses. So we'll have to see. I don't think we know enough. But I think what this is pointing out to us is we're in a universe where viruses are going to be jumping from animals to humans, not rarely. And, climate change has a lot to do with this. And this is usually the point where all the Republicans roll their eyes, but it's the truth. That's part of it. There was a recent study actually that showed that climate change would make 58% of identified infectious diseases a lot worse, either spreading farther or having an easier time transmitting, or having bigger reservoirs or what have you. So yeah, I mean, we're not going to be surprised if we see other viruses showing up. And we're just going to have to be ready. I mean, the beauty of this RNA technology that allowed us to make a COVID vaccine in 100 days is we can do that for a lot of other viruses. We had an advantage in that we understood the structure of coronaviruses and we knew this was a coronavirus. So we knew a little bit about coronaviruses in general. This wasn't a completely alien virus. It was just a new member of a family we knew about. And we knew that they have spike proteins, which we knew because they're on the surface of the virus would be a juicy target for a vaccine strategy. And so that's how we knew what to do. As soon as we discovered the virus, we knew what in the virus to target, and we got busy making a vaccine. But RNA technology will allow us to make other vaccines just as quickly once we have genetic sequences. Although some of the viruses may be unfamiliar enough that there may be a little bit more needed to figure out how to make a vaccine. We actually were able to move pretty fast with COVID because it was related to viruses we were familiar with. We benefited from some of the research that was done on the SARS outbreak when it happened, 10 years earlier.
All right. Well, we don't want to keep you longer than you expected, and we definitely want you to feed yourself because we know that you're extremely busy with all the work that you're doing in the Bassett system with your residents. Thank you so much for taking the time on your Saturday night to come talk to us.
Always, the questions were excellent. The discussion was great. I really just have so much respect for this community, and I was honored to be asked and always happy to participate. I hope it was useful. I thought it was a great discussion, and I'll be happy to circle back around and next time, whenever you guys want me.
Awesome.
Thank
That would
you.
be
Thank
awesome.
you so much. Thank you.
Absolutely. Bye, everybody.
So we'll say goodbye until our next roundtable, which is on Tuesday on Zoom at 4 o'clock and Friday in person at 5:30. And just stay tuned to your email for that information. Have a great night.
Good night.
Thank you.